Thank you. Thank you for the invitation to be here. I'm sorry I'm running in and running out. We have our annual Chief Medical Officers, Chief Science Officers meeting going on today, so I'm running between meetings. And some of you should be at the other meeting, and I know who you are. And I will find you, and we'll talk about that later. So thank you for being here, for allowing me to be here. As Sharon mentioned, the National Health Council held a roundtable at the end of July, and we released our white paper from that roundtable on patients' perceptions of real-world evidence. We had about 50 people. They were predominantly, heavily, the majority of the people in the room were patient advocacy organizations, and we broke them up into workshop tables and asked them particular questions about their views about real-world evidence, what they thought about it, what they thought it was, what their definition of it was, asked what they needed to know about it in order to be able to trust it and use it, and how they would use it, what they thought about using it. And then we asked them about what kinds of tools and resources they would need in order to be able to make the best use of that kind of information in their own decision making. And we took the answers from all those questions and the reams of paper that get stuck to the wall all around the room, and we turned that into the white paper that was released about a week ago. And I want to touch upon 5 points that I heard about today that I think are very related to what you'll see in that white paper, which is available on our website. Dan brought up the breast cancer patient example, which I thought was a great example, because one of the predominant things that came out of the discussion was that what patients really want the most of from evidence is, will this work for me, and am I going to have side effects? And they don't care what kind of evidence it is. They don't care if it's real-world evidence or if it's randomized controlled trial evidence. That's what's going to help them make a decision. And unfortunately, as Dan pointed out, we don't have the answers to those questions most of the time. But if the answer came from real-world evidence, patients would be happy to accept that as long as they could understand that it was as rigorous as possible. And I think that gets into some other parts of the discussion. Another point that I thought resonated, that we heard in that roundtable that I heard today, was about ownership of data. Patients believe that they own their data, and they believe that they should have the opportunity to say who should be able to use it and when they should be able to use it. And as Sharon pointed out, they're very willing to allow their data to be used, but they were talking about how they really wanted to have an understanding of when and how is it being used, and don't I have the right to say that? So I think they would be unhappy about this opt-out situation and would prefer the opt-in situation based on the conversation that happened that day. They also said that in their view, data from EMRs and claims, those data are not authentic, what they called authentic sources of real patient data. And what they meant by that was that those kinds of databases do not include information about patients' preferences, about their experiences, and very often, because they are so clinically oriented or they are so reimbursement oriented, there's a lot of data that does not get captured that are the kinds of data that real patients care about and the outcomes that they care about. And so what they would like to see is that there would be some way to merge these data sources that we typically use, EMRs and claims data, with the kinds of data that are important to patients. Patient-reported outcomes, as Sharon mentioned, and other kinds of data, because that would help with getting the full picture, and it would help with appropriately interpreting the data that come out of the EMRs and the claims data sources because of the added information that would come from patients. The fourth point was that we really learned, and we've been experiencing this over the last year as we've tried to have conversations with individual patients and patient groups about real-world evidence and real-world data, that there's really a lot of confusion about what this means, what the definitions are, and a true understanding of what these things are. And there are different definitions out there that are not contributing to clarifying this at all. They're contributing to more confusion. And so there was a real emphasis on we need some really clear definitions with some really clear examples in order for the patient community to understand what this really is. And there isn't really the need at this point in time to have a public service effort to make the individual patient on the street understand all of this. For an interim step, let's rely on the patient communities, as Sharon pointed out, the patient advocacy groups and the other patient communities who can help be curators of this information and disseminators of this information. But what was really pointed out is they need help. This information is overwhelming and it's very complicated. And so tools and resources are needed in order for those patient communities to be able to separate the wheat from the chaff. And then they can then help their patient constituents by providing information to them that will help them in their decision making. And that was one of the things that Michael brought up was this idea of having a third party that would help make assessments about rigor or something like that. This was also discussed. Like, is there somebody out there who could help an organization figure out whether or not a particular therapy is useful or beneficial based on the kinds of data that come from different kinds of studies? And they also thought, something like a simple tool like making sure that a patient advocacy organization that might be quite small would have access to maybe a scientific board that would help them, or some scientific consultants that would help them in these situations. My last point is one that I think Sharon made a great point of, and that's patient communities as sources of real-world evidence. And they have been for quite a long time. Whether they've been questioned about their rigor, but they've also produced some very good information that's made a major contribution in many circumstances. And so I think one of the things, and I think this piggybacks onto something Joanne said, is can we begin to think about how we integrate all of this information, use it as best we can in order to really look at the weight of the evidence. I was trained as an epidemiologist, and so it's always been the weight of the evidence. Can we pull all of these sources together to really look at the weight of the evidence, regardless of where it comes from? Because we all know there are bad clinical trials out there, and there are good observational studies, and vice versa. And how can we pull that information all together, using the information that patient communities collect, having that be a major contribution, helping to bring in the patient's experiences and perspectives to complement the other information that's out there so that we can really help patients make the best decisions and the best choices. So, thank you.